channel. So this is the first session we are going to start with the cardiology. The cardiology is very difficult one and it is very important in terms of NEET PG. So I request you to pay attention on this. Let's start with the normal ECG. As we know, there is a P wave, Q wave, R, S and T, right? So before jumping to the each and every wave, I would like you to understand the normal ECG paper. So this is a normal ECG paper. For this small box, it is a 40 millisecond. And for this total 5 boxes, it will be 200 milliseconds. So whenever I say one large box, it will be 200 millisecond, and if I say one small box, it will be around 40 milliseconds, right? Then normal ECG comprise of P wave, Q wave, R wave, S wave and T wave. Let's jump to each and every wave. We will understand how these waves are imprinted on ECG, what are the clinical significance and what are the variation we get during this PQRST complexes. So first one is a P wave. What does it signify? It is a atrial depolarization, right? Everybody knows about it. Then second is Q wave. It is a septal depolarization. Now the first question is why it is negative. Let's understand. I will tell you some basic concept behind this PQRST complexes. Suppose this is your body, this is your upper limb, this is your lower limb, this is your left side, this is your right side. In lead 2, the right hand consists of negative charge and the left hand consisting of positive charge. So there is a dictum, whenever there is a charge that flows from negative to positive, we will get ECG in upright position, right? And whenever there is a charge from positive to negative, it will show negative deflection. So any charge that is flowing from negative charge to positive charge, there will be upright ECG, and whenever there is a charge flowing from positive to negative, it will be downward, right? I hope I am clear up to this. Next thing to understand is route of depolarization. Now the impulse is started with the SA node. From SA node it travels to AV node. From AV node it travels to bundle of His. From bundle of His it travels to right bundle branch and left bundle branch. There are two fasciculi, one is anterior one and the second one is posterior one. From this bundle branch, it will depolarize respective ventricles, like here in this case right ventricle and here it will be left ventricle. Now there are few characteristic feature of left bundle branch and right bundle branch. Left bundle branch is short and first to depolarize, okay, and the right bundle branch is longer one and it has a long refractory period. So this is very important thing you must understand. Now again let's come to that body. So this is your body, this is your trunk, right, left, This is your right side of body, this is your left side of body. Now as we discussed, it has a negative charge, the left one has a positive charge. Let's draw the heart as well. So this is your normal orientation, right? Let's see, suppose this is your bundle of his. So this is your left bundle and this is your right bundle. As we said, the right bundle is longer one and the left one is a shorter one, and left is the first to depolarize, right? So what happens here, whenever there is a conduction from bundle of his to bundle branches, left bundle will depolarize first and this will depolarize right bundle branch. So left bundle branch will depolarize first and it will depolarize RBB later. So there will be conduction of charge in this manner from left to right. Good. So can we say that this conduction is following from left to right? Am I correct? So if you apply that dictum, that charges is flowing from positive to negative, then what we will get? We will get negative deflection. So this is the negative deflection that we get in Q wave. So I hope you understand about why the septal depolarization will leads to negative deflection in Q wave. Okay. Now, what about the QRS wave? Why it is a positive one? Let's understand. This is your heart. The size of left ventricle is large, right? It is larger than right ventricle. So whenever there is a charge or whenever there is a depolarization to left ventricle, ECG leads will always consider it as charge flowing towards left side. Since the size of the left ventricle is large, the ECG leads will assume the charge is flowing towards the left side. So if the charge is flowing to left side from right side, and right side is a negative one and left side is positive one, then what we will get in ECG? We will get upright QRS complex, right? So this is the basic reason behind the negative Q1 and the RS upright wave. Now third one is a T wave. What does it signify? It signifies ventricular repolarization. Now what are the normal time limits behind the P wave, QRS complex and T wave? Let's understand one by one. So P wave is normally less than 120 millisecond. That is within a 3 small boxes. What about the height? Height will be less than 2.5 millimeter. In PR interval, what is PR interval? PR interval is AV nodal conduction. What is the importance of PR interval? So PR interval is very important in case of tachycardia and bradycardia. Suppose you did an ECG of a patient and it has a decreased PR interval, right? What does it signify? It signifies tachycardia. Since lower PR interval will suggest that there is a fast AV nodal conduction. this will result in the tachycardia. And vice versa, if the PR interval is increased, the AV nodal conduction is low, so there will be the bradycardia, right? So the PR interval is around 120 to 200 milliseconds. It is 120 to 200 milliseconds. That is, it lies within the 3 to 5 small boxes, right? Then Q wave, as we studied, it's a septal depolarization. It lies within the 40 millisecond, within one small box. Then QRS complex, the normal timing of QRS complex is 80 to 100 milliseconds, that is within 2 to 2.5 small boxes. Then QT interval. What is QT interval? It signifies ventricular depolarization and ventricular repolarization. So time from ventricular depolarization to ventricular repolarization, the normal duration is 300 to 440 milliseconds, that is around 9 to 11 small boxes. T wave, what it signifies? It signifies ventricular repolarization, and its height is important, like it is less than 5 millimeter in limb lead and less than 10 millimeter in chest lead, right? So these are the significant timelines of PQRST complexes and the reason behind the positive P wave, negative Q wave and positive QRS complex. We have understood the normal timelines of PQRST complexes. Let's see the abnormalities. So what are the abnormal P wave, Q wave, QRS complex and T waves? The first one is a P wave. So there are two abnormalities of P wave. First one is a P mitral and the second one is P pulmonale. So where do we get P mitrale? We get it in left atrial dilatation or enlargement. So when the P wave is more than 120 millisecond, we will call it as a P mitrale. Also we can get this notched P wave. And what about the P pulmonale? So it is an increase in height. So whenever there is a height more than 2.5 millimeter, then we will call it as P pulmonale. And where do we get this? We get this in pulmonary artery hypertension, right? The second one is PR interval. To understand the PR interval, there are two diseases that we must understand. The first one is WPW syndrome and the second one is LGL syndrome. So it's a Lon-Ganong-Levine syndrome and it's a Wolff-Parkinson White syndrome. Now let's understand what are these syndromes. The first one is WPW syndrome. Now what happens in WPW syndrome is normally there is a conduction from SA node to AV node to bundle of his to right bundle branch and left bundle branch, and it will give two Purkinje fiber. This will depolarize ventricles, right? This is the normal one. Now what happens in Wolff-Parkinson syndrome is that there is a accessory conduction that is directly from the atria to ventricles. So this is the accessory pathway through which conduction occurs. This accessory pathway is called as bundle of Kent. So understand, SA node has generated impulse. It will give impulse through its natural pathway, that is from AV node, and it will also provide the pathway that is the accessory one from bundle of Kent. Now what happens here is the natural pathway. This natural pathway will have AV nodal delay, and this delay is absent through bundle of Kent, right? So by the time when impulse through AV node reaches to ventricle, there are part of ventricle which is already depolarized by bundle of Kent. This part of ventricle that has been already depolarized, we called it as a pre-excitation. So normally we get this P wave, Q, R and S and T. We get this Q wave. Now during this Q wave, part of ventricle depolarize due to bundle of Kent. And as we studied, whenever there is a depolarization of left ventricle, due to its size, ECG paper or lead will detect it as conduction from right to left. So this Q wave will be absent. So what is the next ECG we get in WPW syndrome is we get the normal P wave, and instead of Q wave we get this delta wave. I hope you understand why we don't get Q wave in this case, because during the Q wave, during the septal depolarization, the part of ventricle depolarizes due to bundle of Kent through this accessory pathway. Since the left ventricle is a bigger size, it will detect as a positive deflection in ECG leads. So we get this type of ECG, and this is a delta wave. So what are the ECG findings in WPW syndrome? First we get PJ interval, right, which is a combination of PR interval and QRS complex. The third one is absent Q wave, and instead of this Q wave we get delta wave, right? So these are the characteristic feature of WPW syndrome. Now what do we get in LGL syndrome? In LGL syndrome, impulse are bypassed AV node through James fiber. Let's understand how James fiber is there in normal impulse. This is SA node to AV node to bundle of His, right? So there is some accessory pathway that is directly bypass the AV node and depolarize bundle of His. This is a James fiber. Even if this is the accessory pathway, but it is following the natural route, right? Just the thing is that there is no AV delay. AV delay is absent. So what do we get? We will get PR interval, short PR interval, delta wave absent, QRS normal. So the difference between the LGL and WPW syndrome is WPW syndrome will have absent Q wave, while in LGL syndrome Q wave will be present. PR interval will be short. PR interval will be short. There will be delta wave absent. Here there is a bundle of Kent and here is a James fiber. So this is WPW syndrome versus LGL syndrome. Let's understand basic ECG axis and how to measure heart rate and all that stuff. Consider this is a normal ECG, right? So this is R wave, this is R wave. So there is a formula, we all know that 300 divided by large boxes RR interval is equal to heart rate. So suppose this is 1, 2, 3. So 300 divided by 3. So it will be 100. So 100 is a heart rate. Now how do we calculate axis deviation? So for this we have to consider two leads, the lead number 1 and the second one is AVF. Lead number 1, this is R wave and this is S wave, and in AVF I am just taking an example, R wave and S wave. So if the R minus S is equal to positive and here R minus S is equal to positive, then it's a normal axis deviation. What if lead 1 has a positive RS, R minus S, and in AVF it is a negative? Then it is left axis deviation. What if it is R minus S in lead 1 is negative and R minus S is positive in AVF? It is a right axis deviation. What if there is negative in both? Then it's extreme deviation. So this is how you calculate the axis deviation. So this is it for the first video. In next video we will understand about the LBB and RBB patterns. I hope you have understand this basic concept behind the PQRST complexes and it will help you in your exam. Thank you so much for watching. See you on the next video. Thank you.